everyone. Welcome to Echo HBV workshop. Thank you so much for joining us. My name is Rachel Deere. I am with DKB Med. I've got my colleagues Faith and Jill here as well. Hi, Jill. Hi, Faith. And we have our wonderful hub faculty, Dr. Calvin Pan. All right. And I know some folks will be trickling in, so we will get started very shortly. Just want to encourage everyone, we want this to be as interactive as possible. So if you're able to turn your camera on, if you're able to come off mute when the time is appropriate, we would love to see you. Understand some of you are in clinic, you may be with colleagues or patients and unable to do that, so no problem whatsoever. You can always communicate with us in the chat if that is something you would like to do. So I'm going to go through some introduction slides because I'm not sure if some of you are aware of what an ECHO program is. So if you're unaware, we will definitely want to inform you on that. So let me get started. But before I do that, I just want to introduce Dr. Calvin Pan. Dr. Pan, why don't you tell us where you practice and what your specialty is?
Oh, hi, good afternoon. My name is Calvin Pan. I'm a hepatology and gastro. I'm a part-time faculty in NYU Langone. I also have a private practice in Flushing, New York. I have been working on the field for viral hepatitis about 25 years. I'm looking forward to share some experience with you and also want to learn from you. Thank you.
Thanks, Dr. Pan. All right. And we will come back once we finish our introduction on what an echo is to hear where you guys are practicing. All right, so why don't I share my screen? And just a friendly reminder, some of your names may appear as a screen name or iPhone. So Faith and or Jill may be reaching out to you in the chat just to confirm your name, because when we want to make sure you get your credit for attending this session. So be on the lookout for that. Okay, require technology. If you're here, obviously you have the technology that you need. So all ECHO HBV models are conducted on the Zoom platform, so want this to be face-to-face, as interactive as possible. So you just need your access either to a computer, a tablet, or a phone. Just note that some capabilities may be limited using phones and tablets. So I'm sure most of you are very familiar with Zoom past few years, but if you would click on the meeting chat and just type where what type of machine you're using. Are you using a computer, a tablet, or a phone, just so that we can get a feel and make sure that everyone knows how to use the chat. All right, I'll give everyone another second as I move along. All right, thanks, Shannon. Thanks, Angel. All right, if you're having any connection issues or any questions about anything, you can contact me, Rachel, or my colleagues Faith or Jill, and we've got our email here and phone number as well. And some folks that are trickling in, thank you so much for joining us. We're just going through a little introduction on what a Project ECHO program is before Dr. Pan goes through his presentation. So the Project ECHO story. Project ECHO was developed by Dr. Sanjeev Arora, who is a liver disease specialist at the University of New Mexico Health Sciences Center in Albuquerque. So this came about because Dr. Arora was frustrated that he could only serve a fraction of the hepatitis C patients in the state. So he created this free educational model and mentored community providers across New Mexico on how to treat the condition. So it's not a traditional telemedicine where the specialist assumes care of the patient, but instead it's more like telementoring, a guided practice model where the participating clinician retains responsibility for managing the patient. So as much knowledge as Dr. Pan has and will share with you, we want to hear from you. We all want to learn in this program together. So the principles of Project ECHO, it's really all teach, all learn. So we want it to be interactive. We would love to see your faces. There will be a co-management of cases, peer-to-peer learning, and collaborative problem solving. You might hear the terms hub and spoke. Dr. Pan is our hub faculty, our specialist, and all of you are the spokes of this model. So the program outline today is just going to be a little bit different because we have some time for introductions and introduction to an echo. But most every week, and it's 4 weeks, we have a 10 to 15-minute lecture at the start of the session that Dr. Pan will do, and then answer any questions that you may have about what you just watched or hepatitis B in general. And then we'll move on to a patient case review and talk about co-managing that Dr. Pan will present. And then the modules, just so you know what's upcoming. So today it's screening and barriers, and then we'll be talking about serology and management, current and emerging therapies, and then co-infections. All right, so I alluded to the case presentation format. So we do ask for volunteers for the next 3 sessions. We really want to hear from you and your patients that you see. So the spokes, all of you, or one of you each week, will present your case. Include any lingering questions about managing your patient, but just good to keep note of that your case doesn't need to align with the lecture content of that week. So if we're talking about serology, you don't have to necessarily speak on that in your case. The time is really best used to help manage your patients. And then our hub team, so Dr. Pan and our other hub faculty will join us for other sessions. They'll summarize the case, ask any clarifying questions, ask for recommendations from the rest of you, make their recommendations, and then summarize those. So a little meet and greet before we get into the presentation and our little pre-test beforehand. Again, if you're able to turn on your camera, we would love to see you. And if you do, I will call on you. And everyone else, if you're able to, just put it in the chat. Let us know, have you ever participated in a Project Echo before? And really, what do you hope to bring to your practice after participating in this program? Your profession, number of years that you in practice, where you practice. We have people joined from all over the country and actually all over the world. We had another group on Tuesday, and we had people joining us from all over. So it's great to meet all of you. And then lastly, and the most important, is our echo clap. Since most of us are muted, we're unable to hear any clapping, but would love to see it. All right. So I am just going to go around for those who I can see. Lena, if you're able to come off mute and introduce yourself. Hello, how are you?
Yeah, I'm just a retired pediatrician, interested in the topic very much. This is my second time on the session.
Yeah, I think we saw you on Tuesday. Nice to have you back. Yeah, so some familiar information, very familiar information, but we've got some new spokes that are joining, obviously, today. So great to have you back, Lena.
Thank you.
All right. And Sai, hi, how are you?
Good morning. I am a retired physician for 4 years already. I'm just interested in the topic. That's why I joined. I've never been to ECHO before.
All right. Thank you. And currently, Dr. Naidu, how are you?
Well, and you? Hi, can you hear me?
Yes, we can.
Okay, all right. I am Dr. Kurtli Naidu. I'm all the way from South Africa. And yeah, for the past 5 years now as a physician.
All right. Thanks so much. And other folks, feel free to put it in the chat, where you're from and what you're practicing. And again, thanks so much, everyone, for joining us. Before I hand it over to Dr. Pan, we have a very quick pre-test that I'm going to launch. And thank you again, Faith. All right, so prior to screening for hepatitis B, I educate my patients on the modes of transmission. So this is what you're doing currently. Would you say always, often, sometimes, rarely, or never? And again, if you're on a tablet or a phone, you may have to scroll down, or even if you're on a computer. Question 2, which of the following is the most common method of hepatitis B transmission in Asian countries? And we're going to revisit this question and others at the end, so pay close attention to Dr. Pan's presentation because he will get the answer, and we're hoping for 100%. Would you say mother to child transmission at birth, injection drug use, sexual activity, or traditional medicine like acupuncture? Again, this is in Asian countries. We actually started this Echo HBV Global Series in Thailand, and then we moved over to China and bringing this to the US. So it'll be interesting to compare the responses. All right. And the third question, approximately how many patients you see each week who are at risk for hepatitis B? None, 1 to 10, 11 to 20, 21 to 30, or 31 to 40. All right. I will stop the poll. All right. So without further ado, Dr. Pan, I'll turn it over to you. Dr. Pan's going to share his slides.
All right. Thank you so much for joining us this afternoon. Very excited. I have some new data to share with you. And also, after the discussion, I love to hear your case, your comments, or maybe I can share a case if you don't have one. So hopefully through this discussion, we can learn from each other how we should do screening, how we could identify patients at risk and understand some of the basics of the transmission mode. Wonderful. So today's ECHO program, module 1, we're going to talk about screening, identify patients at risk, and also would address some of the stigma of hepatitis B and try to figure out how we can overcome some barrier or challenges through the screening. Now let's just start with the impact of the disease. In general, globally, we have close to 3 million people, individual infected with hepatitis B. In the United States, it's about 1.5 to 2 million. Now it's growing number because the new immigrant from Southeast Asia. We'll discuss later on why Asian American actually have more chance to get hepatitis B. It's because in Asia, they have vertical transmission, mother to child transmission. If those patients infected with hepatitis B, untreated and monitored, eventually about 40% of them could develop liver cancer or cirrhosis and have be as much contagious than HIV. We'll talk about the transmission mode later. So why is that important in the US? Because this is a country with a lot of immigrants. And for the last 20, 30 years, actually the immigrants, proportion of immigrants from Asia actually is much more than those from the Europe. So the vertical transmission, mother to child transmission in Asia, leading to a high incidence or prevalence of the disease in Asia as an immigrant come to the United States, and actually can increase the number of patients in the US with hepatitis B. Now, among all the Asian countries, Chinese, here you showed it in the blue curve on your right, and showing as a higher prevalence in Chinese population, patients from China or individuals from China actually have a chance of 6.9% of them infected with hepatitis B. WHO, because this disease has a huge burden, financial burden and disease burden, WHO declared that by 2030, we need to eliminate viral hepatitis, mainly hepatitis B. We try to achieve the goal, 90% reduction in the new infection and 65% of reduction in death. Because every year, we estimate about 800,000 people die of liver cancer associated with hepatitis B. So this is a very important topic, and we need to understand who is at risk and how to screen them. So identify patient is first step to reduce a new infection and potentially offer them a treatment reduce death. Here it shows you the comparison of patients who have hepatitis B from Asia versus in the developed country like Europe or United States. The transmission mode is different. In Asian country or developing country, including Africa, South America, particularly in Asia, about 1/3 of those patients actually is from Asia for hepatitis B. They're all from, almost 90% of them are from mother to child transmission. So mother to child transmission is the main transmission mode in Asian individuals. In contrast, in United States or developed country, because we have implemented the hepatitis B vaccine for babies, so therefore the most common transmission mode in United States or in developed country, some of the countries in Europe, mainly is through horizontal transmission. That means from adult to adults through sexual activity or drug use. And why is that important? Different transmission mode may dictate the incidence or prevalence of the disease. Incidence, we're talking about yearly new cases. Prevalence is the whole population. Because in mother to child transmission mode, majority of those infants get exposed to the virus, can develop chronic infection. Here shows less than 1 year old got exposed to HBV. 90% of them become chronic. Up to 5-6 years old, they still have pretty good chance to become chronic. Versus adult population, like most patients get hepatitis B in the United States, they through adult horizontal transmission. After exposure, only 5%. So that actually explains why there's so many patients get infected in Asia versus in the country, in the developed country. The transmission mode is different. There are some misperceptions when we talk about the transmission of hepatitis B. And here lists some of the common fears among patients or who wouldn't get a lot of education about hepatitis B. They worry about some of the transmission mode here actually is not true. For example, can people get hepatitis B when they get kissed by the others or by the individual who have hepatitis B, sneezing, coughing, or even breastfeeding? If the mother have hepatitis B, is not a concern for breast milk feeding, because the virus concentration in the breast milk is very low. If the baby received the vaccine already, it's not a concern. There has never been good data to suggest that could transmit the disease. Not mention about the air, food, it's not airborne disease and not COVID. Water mainly is for hepatitis A, it's not for B. B is a blood-borne disease, just like HIV or HCV. This virus will transmit it through the body fluid or contaminated blood. Here is just showing you that in a horizontal transmit case, when patients get exposed to virus, majority of them, if they're age older than 5-year-old, chances are they get acute hepatitis B, not become chronic here. So here's the most exciting news for the last couple of weeks. In March 2023, just about a month ago, CDC actually updated the guideline for screening of hepatitis B in the United States. CDC recommend that we should do a universal screening. All the adult population should get screened for hepatitis B at least once a lifetime, regardless whether they got the history of vaccinated or not vaccinated. Doesn't matter, everybody. They also suggest even patients older than 65. Some people may argue that if you're older, even your diagnosis, you may not get a good benefit, but CDC still recommend that. So mandate is 65 below adult. 65 is recommended. It's even not mandate, but recommend. Now, not only that, CDC also lists some of the high-risk populations even during the screening, you should give vaccination immediately. And for those with high risk for reinfection, list here, CDC recommend repeat screening, not just one time. For example, if patient have history of STD or multiple sexual partner, patient they may have co-infection HIV, HCV, so they may have the other risk factor, get exposed to blood product, etc., etc. MSM, incarcerated persons, etc. Or if you have a patient even screened before, but now you have another unknown etiology or none of the explanation from the other disease caused ALT or AST elevation, you should screen for hepatitis B again. So here is two approach. On the right, showing is the old approach is what we do the screening test first, and then decided whether give the patients vaccine. But the new approach is on the left, showing the CDC recommend that even you don't know whether the patient is a candidate for vaccine or not, but as soon as you draw the blood for screening, on the same visit, you give the first dose of vaccine. And later on, when the result comes back, you may not need to continue to finish the whole 3 vaccine series if the patient have the Hep B already. So this is the current approach. Recommend that don't missing any opportunity to early vaccinate your patients. So lastly, we're going to talk about a little bit the cultural specific barrier and the other barrier for screening. And we know that the high risk group will be Asian American, but of course, any patients who hasn't been screened before, and now it's easier, and you have to screen everybody. And you also need to repeat the screening for those patients with high risk. But understand there are some barrier for screening, so you may want to address that. For example, patient may lack of understanding, they don't know how expensive this test will be. To be honest, even self-pay, most laboratory in my area charge about $15 for screening. You probably can find out by calling your local lab. So financial concern, patient, they don't know, they thought that the screening would be costed. They may not be able to afford. Language barrier also, if patient coming from Asia, they may not find a language inline provider. So those things might help if you can address, if you have interpreters in your office and try to explain to your patient they all need to be screened at least once. So some of the insurance probably would not cover screening, but I would expect that it would be less resistant because the new CDC guideline actually can promote the general coverage from all insurance, at least any Medicaid, Medicare patients have no issue with that. The commercial would follow. So patient education is the key. You try to persuade them and explain to them the disease burden and the severity of the complication. If we don't get an early diagnosis, you won't get a window period to manage them, monitor them, or even treat them and reduce the complication. So you should highlight the HBV is transmittable through sexual activities, etc., etc. So if one person diagnosis in the family, the other close contact probably should get monitored and screened and vaccinated appropriately. So clinical barrier, we talk about some physicians may not, like you, spend time and study this disease and update yourself, and they still get confused, get the serology result and not responding accordingly. That's why we're doing this. We try to promote the awareness and try to get more people involved so that we can identify those patients and help to eliminate the disease. So solutions, we talk about, explain to your colleague about the CDC guideline. You actually can help to spread the news, update them, tell your colleagues there is a new guideline mandated. Everybody in the practice should screen their patients and also understand how screening can help to identify those patients. You can use your leverage your EMR system, probably talk to your administrators and see if you can get a pop-up window in your EMR and showing that CDC require universal screening and see if this patient actually have missing the opportunity to get screened. So we talk about a couple barrier, patients barrier needs education, physicians barrier. We also need to do CME activity and get them involved. Cultural barrier needs to address, and finally, systematical insurance support and hospital systems, integrated screening strategy. Those things would help to resolve the barrier. So I think with that, I thank you for your attention, and I think we can get into the case discussion.
Thanks so much, Dr. Pan. And I know some folks joined during the presentation, so welcome to ECHO HBV. I'm your facilitator, Rachel with DKB Med, and I've got my colleagues, Faith and Jill here, and then Dr. Pan is our presenter. So thank you again. Again, this time we'd like to spend time answering any questions that you might have, any questions for Dr. Pan about anything that he presented. So if anyone has questions, feel free to put those in the chat and I'll read those aloud. But also, we really do encourage you to come off mute and to ask your questions vocally. And you can also use the reactions, like the little clap that you're seeing next to me. All right, and Faith as well, so to get our attention. All right, I actually have a few questions that came in directly from me. So Dr. Pan, one question, and I'll put it in the chat too so folks can see it, and I'll read it aloud. Why should we test all adults for hepatitis B if we know that they are vaccinated?
That's a great question. Vaccination doesn't mean can eradicate the disease. And particularly, many patients, they got vaccinated, they may not be checked on hepatitis B before vaccination. So the purpose of screening everybody is try to capture those patients have the hepatitis B, but they still get vaccinated. And I think that's the approach. Because as we have seen the data, the disease, if you don't diagnose it and manage them, and patient would die 40% of chance from liver cancer or cirrhosis. And screening is very affordable as we talk about the life-saving strategy. So because vaccination doesn't automatically clear the Hep B infection. If they got infected, they vaccinated, they still have the disease.
Dr. Pan, I have another question. I put it in the chat. In the US, how likely is it that someone who has acute hepatitis B from injection drug use will go on to develop chronic hepatitis B?
That's another great question. I think we can use this question to revisit what we just talked about. United States infection versus in Asia, in Asia, some country they have mother to child transmission predominant. In the US, we talk about predominant transmission mode is the horizontal, adult to adult. So you saw two slides. One is showing that the age over 5, the acute hepatitis B is more common. 90% they got acute hepatitis B, and only 5 to 10% if they are older, if they're adult age, after exposure, they can get chronic. So the correct answer is less than 10%. They can get chronic infection. Most of them, 90%, they got acute infection and clear by himself, most likely, because among the acute infection, less than 1% develop a very severe complication called permanent hepatitis. They totally liver failure and may require liver transplant. So that's a worse scenario.
All right, and Sai asked a question in the chat. Do you still screen patients who are seropositive but later seroconvert to negative? In other words, do patients who are seroconvert to negative become positive again?
I think there are a little bit confusion in this case. If you're talking about seropositive, documented, have a lab test, this patient have hepatitis B already. If you confirm the patient have a lab test showing they have hepatitis B, they're not falling into the screening criteria because they have the disease already. So we're talking about screen everybody. I should put it in a way that help you to understand better is, except those that have confirmed the diagnosis of hepatitis B, you don't need to screen that they have the disease. So in other words, once they have hepatitis B, the disease, now Hep B is not cured, and you don't need to pre-screen them. You need to monitor them and see if they need treatment, they have any complications. So for any diagnosis, confirmed diagnosis of hepatitis B patients, you don't do screening. Screening is for non-confirmed Hep B infection individuals. Does it answer your question?
Yes, thank you. That answered my question. Thank you very much.
All right, and Shannon put just some notes in the chat. Shannon's having some issues with audio, so I'm hearing everything okay. Is not if Faith and Jill, are you hearing everything okay? Yeah, no one else has mentioned anything, Shannon, so we'll just keep an eye on it. But we are recording this, so you'll also get a link to the slides and to this video. So if you missed anything, don't worry, you can watch the video and take a look at anything that you might have missed. All right, so let me scroll back up. Dr. Kirtley had a question. My question is, as surgeons, we have to be vaccinated, but as time goes on, our immunity decreases. Will we require booster vaccinations?
That's another question, wonderful question in terms of booster. Once you got vaccinated and you check your titer, if it's up to the protected level, we consider as 10 units. Once you get up to the level, the answer is no. You don't need to be boosted because your body's immune cells, particularly T cells, they will memorize the structure of the viral protein. And when you got the real virus get into your body, it will boost your immune memory and response, both cellular and T cell, B cell immunity. So the answer is no. Now, the other scenario would be you got vaccinated, but you could not get up to the protective level. There is no consensus. I have the privilege of writing the new guideline for this country, hepatitis B new guideline in 2023. I chair the group. We review the evidence now. There is no great evidence to guarantee that everybody could get a very optimal level. It's about 2 to 3% of those people for genetic variation or susceptibility, they couldn't get up to that level. But what to do with that? There is very few data can address that, because the small amount of these people, it's hard to run a clinical trial to compare one approach versus the other. So currently there are some variations in the practice. Some experts will advocate that you could double the dose and boost the immunity. Well, of course, we know if patients immune deficiency like HIV, diabetic, they probably have suboptimal response. But I would presume a surgeon, a healthy surgeon like you or your colleagues, probably would not have immune issues. But for those who have intact immune system, probably double the dose, or you can try to use a Hep A and Hep B vaccine together, even though you may have a Hep A antibody. So two antigens simultaneously stimulate the system may produce optimal. You may try one method or two maximum. If you couldn't get there, you couldn't get there. And there's no better way. to do that because currently there are only 2 vaccines available in the United States. One is using a 3-dose series, the old way, and I believe a GSK, and another one is the most recent one called VACCINATION by Dynamax, and it's just 2 doses. So another approach is, you may use the other manufacturer's product instead of using the same product when you do the second round.
All right, thanks, Dr. Pan. We'll take a couple more questions before we move over to the case. All right, and I will put it in the chat because it was sent to me. Dr. Pan, is reflex testing as good as the new triple panel test?
I guess this question, we have that before. So the quick answer is no. The new CDC guideline requires you do a triple panel because you want to know whether your patient have totally nothing, no immunity and no infection. You need to continue to give the vaccine to your patient to protect them. So right now the vaccination strategy is as soon as you draw the blood for screening, the triple panel, you get the first dose already. If you're only doing the reflex test, you wouldn't get the other information whether a patient should complete the vaccine series or not. And also the core antibody is important to know. On your module 2, we're going to talk about how to interpret this. But since we are mentioning the triple panel, I just briefly emphasize the core antibody is very important to know. If the core is negative, then you don't have to worry about it. If the core is positive, even the surface antigen is negative, you still imply the patient may have virus in the body and could reactivate later on. For example, if they have cancer therapy, chemotherapy, or the immune modulator suppress the immunity, they can reactivate.
All right, thanks, Dr. Pan. We're just gonna, I know that a couple other questions came in. I just don't want to lose track of time. So Dr. Pan, I'm going to share the case, and if we have time to revisit any questions, let's do that.
That's great.
All right, and I will share my screen with you. All right, so this is our first case for this week. Dr. Pan will kind of talk through, and I alluded to at the very beginning, I know some folks joined later, but we would love to have any volunteers for the next few sessions. We have a patient case form we can share with you. Could fill that out as much as possible, and then you can present that, and we just ask that you send it to us prior so Dr. Pan could take a look at it, provide any of his recommendations, and then your peers when we meet back. So I'll turn it over to you, Dr. Pan.
Okay, thank you so much. I'm going to read this case to you. Since some of you actually joined us about a couple of days ago, so you have seen this case before, I'm going to twist a little bit on this case and ask different questions, and hopefully can make this more fun when we go through the case. So this is a 65-year-old male patient, let's say from Vietnam, with chronic hepatitis B. He was treated with antiviral therapy with lamivudine about 13 years ago because persistent elevation of ALT, presume at that time you have virus, certain level of viremia. Now, after 10 years treatment, he had been doing fine, undetectable. Then about 5 years ago in 2018, the chart showing that during a regular follow-up, his DNA bounds up to 5 logs, approaching to 6 logs IU. His ALT is still normal. As his primary doctor, at that time, what would you suggest to do based on this result? Any takers?
What would you suggest? Anyone? And you can put it in the chat, or you can come off mute and ask it.
I will refer the patient to our infectious disease specialist for recommendation.
So you will refer the patients to the ID
Yes.
specialist.
Yes.
And that's one way to go. Get more help or hepatologist. Now, I know you probably want this patient in a specialist's hand to handle his case, but how about if this gentleman asks you, Dr. Mui, what about my family? Should I bring my wife? I have 2 kids, 1 daughter born in Vietnam. My son is born in the United States. They all they all got vaccinated. The Vietnam one, I'm not sure, but in the US, my son have been vaccinated. What would you recommend in terms of the wife, the daughter, the son? Do you want to screen them?
Yeah, I will screen every one of them.
So you will do all 3?
Yes. Even if they are vaccinated, I will still screen every one of them because of they live in the same household.
Right. So that's a correct approach. I think somebody asked a question is, why patient got vaccinated, they might still have hepatitis B. Just let you know that if the mother have a very high viral load, even the infant got the HBV and vaccine, the hepatitis B immunoglobulin when they deliver, and also receive the full vaccine, they still have like 10 to 15% chance the virus can break through the vaccine and HBV and get infected. So immunoprophylaxis is not 100% success. So given that record and showing the baby have been vaccinated doesn't automatically rule out the patient have an infection. So I 100% with you. The second question I want to ask the whole group is, what do you think if Dr. Mui get the patient screen, the baby, not the baby, the daughter born in Vietnam actually get hepatitis B, and the son doesn't have hepatitis B, and what might be the chance of vertical transmission versus a horizontal transmission for the daughter? What do you think? Which mode of transmission? The daughter was born in Vietnam. What is the likelihood of transmission mode?
It's probably vertical.
Let's say the mother also tested positive for hepatitis B.
The more likely thing is the daughter got vertical transmission.
Yeah, wonderful.
It's more common.
If you identify the mother have hepatitis B, 90% of time it's mother to child transmission, particularly they are in Asia. Because even now in Vietnam, there are only 50% of those babies could get HBV and vaccine at delivery timely. So the virus could be well seated in the baby's blood during the delivery, because when you have the baby deliver, we know that the placenta got tear off, right? Before the baby came out, then the tear itself would mix the maternal blood with the baby's circulation. And if you don't get the vaccine or HBV on time, the recommendation is within 12 hours, the baby got infected already. Even later on, you can give them tons of vaccine or the others, it's not going to help. So again, in Southeast Asia, because of lack of the timely immunoprophylaxis, if the mother have the hepatitis B, the baby more likely, almost 90% of time, if they are happy, they got mother to child transmission.
And Dr. Pan, if you'll read aloud, we've got a question from one of the learners in the chat about lamivudine.
Okay, he says, if he's still taking lamivudine, I would like to know more about his serology, e-antigen, e-antibody, and need them to get tested, vaccinated. Well, he is still taking the lamivudine. That's what happened. But if you want to know his serology, his is still E antigen positive, and E antibody negative. What would you say to him? I give you the result. He's still taking the memadine. It's E antigen positive, E antibody negative. What would you like to recommend? And you have the viral load almost 6 logs. Actually, it really doesn't matter whether it's E positive or negative. If you have a viral load of 6 logs, that's a whole lot of risk of transmit the disease to his wife, at least. Then what would you recommend to his wife, to his kids? Do you agree with Dr. Mui that you should bring them in? I think it's not only for the family, or good for your business too. All of a sudden you got 3 patients, extra 3 patients within your practice, right? And then you should do what? Do you want to screen them?
If the wife is already having the hepatitis B infection already, so there's no chance that the husband going to be infecting further, right? He has got it. He's still hepatitis B positive, so he's
right. I agree. Like Dr. Mui said, if you bring them in first, if the wife show you that, oh, I got a blood test from my primary doctor, 2 years ago, and show I have surface antigen positive already.
Right.
You don't need to screen the wife. He got it. She got it. There's no way this disease will go away by itself. So what if the son and the daughter said that, no, I never know. I know we got vaccinated, but I don't know my status. Then you need to screen them. If after screening the daughter would be positive, then the same scenario, the daughter most likely got it from the mother. Unless you prove the mother, before the daughter was born, the mother had been negative, documented. Maybe later on it's through the sexual activity and get transmitted from the husband. So those are little twisted on the case, and hopefully we can relearn those knowledge how to screen. Now, for the son, you screen, you offer the screen, and the son said, okay, today I can draw the blood. Would you vaccinate the son?
He got vaccinated already, right? He got vaccinated in the past.
Yeah, even he got vaccinated in the past. But if you don't have a reliable record showing the patient has immunity, giving the high risk, right? The family, you got 2 down already, the father and the wife, even though the daughter is pending, I would recommend give the first dose of vaccine when you draw the blood from the son, because you're not sure the son have the immunity or not.
Okay, so when you draw the blood, you also check the titer, antibody titer, right?
Right, you can check whatever you like, but give the vaccine on the same visit. That's the CDC new guideline I recommend. Now, what if 2 days later, the report come back and showing the son's indeed have the immunity above 10, right? It's fully immune. Then you can stop right there, or tell the son you don't need the 2nd dose or the 3rd dose, you're good enough now, right? Now, if the son have no immunity, then you continue to finish the 2nd shot, at least, if you use the Dymax vaccine, 2 shots. If you use GSK, that's another additional 2 vaccine. Usually the vaccine is like 1 month later and 6 months later. Does it make sense to you? So we emphasize the new CDC guideline is as soon as you draw the blood for screening, that means you will confirm the patient have no evidence of active disease or infected already. That's why you're doing screening. Then by the same token, the patient still at risk for new infection. give the vaccine at the same visit. Then we go from there. When you get the result come back, you decided you can stop right there or continue to finish your vaccination series.
And Dr. Pan, I just want to jump in. One of the learners messaged me directly, and we are running low on time. We need a little time for the post-test, but I just want to mention the comment. The patient needs to be changed to TAF and family needs to be screened, treated, or vaccinated as being discussed.
Just briefly, the first thing is try to see if the patient compliant with the medication. If it's compliant, yes, I will agree with you. You may need to test the resistance and then change the medication.
All right. Thanks, Dr. Pan. Thanks, everyone, for your questions. And Joseph, we didn't get to yours, but I promise we'll make a note and we will address that. That'll be the first question next week. All right. Thanks. Okay, and let's move over to the post-test. All right. Faith, are you seeing it?
I'm not seeing it.
Okay, you should be now.
There we go, now I am.
Okay. All right. So first question, it's about your confidence now. As a result of this activity, how confident are you now in overcoming stigma regarding hepatitis B in your practice? Would you say you're much more confident, moderately confident, somewhat more confident, or not more confident? And then that question 2, we saw this at the very beginning. So which of the following is the most common method of hepatitis B transmission in Asian countries? Mother to child at birth, injection drug use, sexual activity, or traditional medicine like acupuncture? And I'll give everyone a moment to answer that. And again, thank you so much, everyone, for joining. Really appreciate it. We will see you the same time next week. And again, any questions that might come through between now and then, make note, or you can email us at echo@dkbmed.com. And at this time, Faith will put the link to the evaluation in the chat. So if you are in need of CME or nursing credit, this is accredited for both of those things. We just ask that when you take the evaluation, you're signed into your DKB Med account. Sometimes there's some confusion with that if you're using a different computer. So just make sure that you're signed into the account, and Faith has put the link in the chat. And like I mentioned at the very beginning, we are recording. So look for an email from us. You'll receive a link to the slides as well as the recording. So if anything was missed, you can refer back to it. All right, let's end our poll. And let's see, it looks like our confidence has gone up drastically. Wonderful. And 100% of us said mother to child transmission at birth. Dr. Pan, what's the correct answer here?
Yeah, that's the correct answer. I'm so glad that none of you actually fell to sleep and we got through this with very, very fantastic result. And I'll say that you guys are the best. I never seen a group get 100% by far. You are the one.
Yes, as I mentioned, we've done this this echo series with some groups in China and Thailand, and I don't believe they got 100%. And we just did with another US group this past Tuesday, and they were high, but not as high as 100%. So well done, everyone. So we will see you next week at 12 p.m. Eastern. Can't believe it'll be May, but May 4th for Module 2. Don't forget our echo clap. And again, thank you so much. And the link to the evaluation is in the chat. And we'll see you next week. Thank you so much, everyone. And thank you, Dr. Pan. Take care.
Take care. Bye-bye now.
Thank you. Bye-bye.
And have a happy birthday, doctor.
Yes, happy birthday.
Thank you.
Bye-bye.
Bye.